Uterine fibroids, or leiomyomata, are benign monoclonal tumors that originate from the smooth muscle of the myometrium. They represent a significant clinical contradiction. While they affect up to 30% of reproductive age women and 75% of cases are entirely asymptomatic, they remain the primary driver of heavy menstrual bleeding and the leading cause of hysterectomies. The anatomy of the tumor is distinct. As a fibroid grows, it is encased in a pseudotapsule formed by compressed adjacent myometrium. This creates a centrifugal vascular architecture. Blood vessels run radially through the capsule, which often leaves the core poorly vascularized and susceptible to ischemia. This encapsulated avascular core structure is the physical basis for the complications, degenerative changes, and surgical risks encountered in clinical practice. Development is often tied to genetic predisposition. Approximately 50% of cases show chromosomal abnormalities, most frequently translocations between chromosomes 12 and 14. The tumors are hormone-dependent. They contain a higher density of estrogen receptors than the surrounding normal myometrium, relying on estrogen, progesterone, and polypeptide growth factors to expand. This growth is slow. It typically takes 3 to 5 years for a fibroid to become large enough to be felt during an abdominal exam, and they naturally regress after menopause. Epidemiological risk factors mirror this hormonal dependency. Conditions with uninterrupted estrogen exposure, such as obesity and nulliparity, increase risk, while multiparity and smoking offer a protective effect by altering estrogen metabolism. Ultimately, a fibroid is an estrogen-driven architectural distortion. This explains both the demographic patterns of the disease and its reliable regression once ovarian function ceases. The FIGO staging system categorizes fibroids based strictly on their spatial relationship to the endometrium and the serosa. Submucosal types, designated 0, 1, and 2, protrude into the uterine cavity. Even a very small mass here can cause severe menorrhagia and drive infertility by preventing embryo implantation. In contrast, intramural and subserosal types project toward the outer walls. These can grow significantly into the peritoneal cavity without ever disrupting the uterine lining or causing abnormal bleeding. Type 8, or cervical fibroids, produce severe pressure symptoms. An anterior cervical mass typically causes bladder retention, while a posterior mass causes rectal constipation. A patient's symptoms and the complexity of their surgery are dictated by these specific anatomical coordinates, rather than the absolute size of the tumor. Symptomatic patients typically present with progressive menorrhagia and congestive dysmenorrhea. If a polyp becomes ulcerated, they may also experience metrorrhagia, continuous, irregular bleeding. On general examination, the clinician primarily looks for varying degrees of pallor, indicative of chronic anemia from blood loss. An abdominal exam may reveal a firm nodular pelvic mass. These are characteristically non-tender, dull on percussion, and show restricted mobility. During a bimanual exam, the clinician feels for an irregularly enlarged uterus that is continuous with the mass. There is no distinct groove or separation between the mass and the uterine body. You confirm this using the transmitted cervical movement test. When the abdominal mass is moved, the cervix moves simultaneously, proving the mass is of uterine origin rather than adnexal. In the case of a central cervical fibroid, the lantern on the dome of St. Paul's sign may be present, where the small body of the uterus sits atop a massively expanded cervix. The physical exam serves to isolate the mass to the uterus and map its mechanical disruption of the pelvic space. Transvaginal and abdominal ultrasound are the first-line investigations used to locate, size, and count these masses. A color Doppler ultrasound confirms the diagnosis by showing vascularization at the periphery of the mass with a distinct lack of central flow. This imaging is critical for distinguishing fibroids from adenomyosis. While both cause an enlarged, bleeding uterus, adenomyosis typically presents with symmetrical enlargement and a uterus that is tender to the touch. MRI is used to definitively differentiate the two, identifying the fibroid's distinct capsule or the thickened junctional zone characteristic of adenomyosis. Saline infusion sonography and hysteroscopy are employed to evaluate intracavitary pathology, allowing for direct visualization and, in some cases, the simultaneous resection of submucosal tumors. This radiological mapping provides the necessary data to bridge clinical suspicion with a surgical plan. Over time, the avascular core of a fibroid can undergo secondary changes. The most common is hyaline degeneration, which may progress to cystic liquefaction. Red or carneous degeneration is an acute complication typically tied to the physiological stresses of pregnancy and the puerperium. This is a form of aseptic subacute necrosis. When the blood supply is outstripped, the core undergoes infarction, turning a salmon pink color as blood pigments diffuse. Patients present with severe pain, localized tenderness, a mild fever, and leukocytosis. Management must be strictly conservative, utilizing rest and analgesics. Immediate surgical intervention is avoided. Identifying these signs of red degeneration prevents unnecessary and potentially dangerous surgery on pregnant patients. Management begins with expectant watch and wait criteria. This is appropriate for asymptomatic patients, masses smaller than 12 weeks in size, or women approaching natural menopause. Medical therapy, such as GnRH agonists, is used preoperatively for approximately 3 months. This induces a state of hypoestrogenism to shrink the tumor and correct anemia. Surgical options are dictated by reproductive goals. A myomectomy is indicated when a patient wishes to preserve fertility, while a hysterectomy remains the definitive treatment for completed families. Uterine artery embolization serves as an interventional radiology alternative to surgery, though it is generally avoided in patients with pedunculated masses or those desiring future pregnancy. Submucosal fibroids require a specific approach, utilizing hysteroscopic myomectomy to resect the mass from within the uterine cavity. Management is a negotiated pathway that must account for both the patient's symptoms and their reproductive timeline. Consider a 35-year-old nulliparous female with progressive heavy menstrual bleeding, pelvic pressure, and a 2-year history of primary infertility. Her exam reveals clinical pallor and a firm 14-week size non-tender mass that moves in tandem with the cervix. Labs show a hemoglobin of 8.5 grams per deciliter. An ultrasound identifies a 6-centimeter FIGO type 2 mass with peripheral flow. The management involves 3 months of GnRH agonists and iron therapy to resolve the anemia and reduce the mass. This medical stabilization is followed by a fertility-sparing hysteroscopic or laparoscopic myomectomy. This comprehensive algorithm directly addresses the immediate physiological need to stop the heavy bleeding, while achieving the long-term goal of preserving reproductive anatomy. Effective management of uterine fibroids requires spatial awareness. The FIGO classification system allows clinicians to predict specific symptoms and plan surgical interventions by mapping these anatomical coordinates. A critical step is distinguishing fibroids from adenomyosis via MRI or detailed ultrasound before proceeding with surgery on an enlarged, bleeding uterus. Gynecological care requires treating the individual patient's symptoms and timeline, utilizing the full continuum of care from watchful waiting to surgical resection.